Modern psychiatry operates on a foundational idea that human mental life is generated inside the physical skull. The outside world supplies inputs, but the mind itself sits isolated in the dark. This view translates human distress into internal dysfunctions. It treats the mind like a biological circuit board, where emotional suffering is the result of faulty wiring or chemical imbalances, waiting for correction. Symptoms are measured, categorized, and scored. Neural regions are isolated and labeled, with standardized protocols to manage clinical risk. This model has practical uses for classifying illnesses and directing research, but it creates a gap in how we understand the person in front of us. The system commits a category error. It takes the abstractions generated by its own methods, the scores, the scales, the criteria, and mistakes them for the primary reality of a patient's suffering. A clinical rating scale captures a shadow of depression, but it misses the lived texture of the person's days. A diagnostic category serves as a tool for classification. It is not a complete portrait of a human life. While neuroimaging shows biological correlates, a brain scan cannot measure the weight of an unspoken history or the quality of a person's social connections. Statistical significance in a clinical trial differs from the restoration of human flourishing. A patient can fall below a diagnostic threshold and still be unable to live. By over-identifying with the isolated brain, psychiatry has built a system that is precise in its methodology, but impoverished in its understanding of the living person. To address human suffering, we can invert the starting point, moving the focus from the disease object to the whole person, situated within their environment. The brain mediates signals between the body and the outside world. Environments like secure housing and community keep our internal systems balanced. Our biological rhythms are co-regulated by others. When relational structures vanish, the nervous system loses its anchor, and its regulatory capacity fractures. Clinical care that extracts the brain from these living systems remains inadequate. We cannot fix the mediator if we ignore the field that is meant to mediate. The mind follows the dynamics of a moving river. It is an ongoing process of movement through a landscape of memory, body, and time. Well-being is a state of flow, the capacity to move through difficulty, adapt to change, and continue to make meaning. Distress often manifests as flooding. Trauma or grief can overwhelm the system, pushing pressure far beyond a person's capacity for containment. In other moments, the mind stagnates, the current slows to a trickle, and life feels blocked, inert, and unable to move forward. Rather than searching for a malfunctioning part, the clinical task is to identify exactly where the ecosystem's flow has been disrupted. This changes the clinical question. We stop asking how to stop the river and begin asking, what kind of banks does this river need to flow safely? Many psychiatric interventions function as walls. They rigidly block or suppress symptoms to manage risk, which can inadvertently cut off a person's vital movement. We are aiming for living banks. These are supportive structures that contain and protect the individual while allowing their life to move. Medication and therapy can serve as these banks, but so do debt advice, stable routines, and spiritual practice. These are not social extras, they are clinical necessities. We evaluate every intervention by a single standard, whether it restores the safe flow of the person's life. This leads to new diagnostic questions. We must identify what is flooded, what is stagnant, and which structures have been eroded over time. This approach relies on specific principles: human dignity, ecological awareness, cultural humility, and a hopeful realism. This shift demands a science that is adequate to the actual complexity of a human being. The mind arises from the active relationship between the brain, the body, and the world. Sustainable recovery begins when we start from the reality of the living person in their living field. Practice starts there.